Very good. It's now 15 after the hour, so we will resume our meeting at this time. Before doing so, I would like to make certain comments that I believe are within my purview as the chair of the ACIP. It's been brought to my attention that through various outlets, misinformation and statements made to impugn and undermine the work that the ACIP has carried out over these last 9 months, and more specifically, over the last 2 months, and caused doubt among the American public as to our motives and decisions. It has been said that our recommendations are excluding specific racial groups. It is important that the public understand that throughout the long period of deliberation, the thoughtful discussion, the careful evaluation of the data, the ACIP has struggled painfully to deal with distribution of a limited resource of vaccine. Our attempt has been always to achieve equitable, ethical, and fair distribution of that resource. We have never targeted a specific ethnic nor racial group for receipt of the vaccine. Our decisions, recommendations better said, for the groups that are priority take into account the burden of disease within those groups. And within those groups, white, Caucasian individuals predominate. The statements being made and carried throughout various outlets undermine the careful work that we have provided and undermine the trust of the American public in our committee. I want to emphasize again, we have never focused on any particular ethnic or racial group in coming to our recommendations. Thank you for allowing me to address that. Dr. Cohen, do you have a slide for us or wish to make other comments?
Yes. No, thanks, Dr. Romero. So before we move on to any final discussion or vote, I want to make a couple of announcements, and then we are going to review the current list of CDC high-risk recommendations and some of the language in our clinical considerations around what is a high-risk individual. We want to provide this information and get some input from ACIP, but we can continue to discuss this issue at future meetings. My one announcement I want to make is that the MMWR on the Moderna COVID vaccine is now live, thanks to many people who got that out rapidly. It is also, there will be clinical considerations, which if they're not live yet, will be very soon. It sounds like they are live. That accompany both of the mRNA vaccine products. It is one clinical considerations document. If the vote today, if ACIP approves the recommendation that is on the that is being considered, that has been proposed and seconded, we will have an in that decision has been approved by the CDC director. We will have an MMWR published this week to describe this prioritization, these interim prioritization recommendations, along with another clinical or implementation guidance document to accompany that MMWR. So I just want to clarify what everyone can anticipate will be the products from these meetings. I'm going to hand it over to Dr. Dooling, who's going to review the current way we're thinking about high-risk medical conditions or conditions.
Thank you, Dr. Cohn. So this is in response to some of the questions that were posed earlier by ACIP members and liaisons, specifically to address the conditions associated with severe COVID, or what are referred to in the slides as high-risk medical conditions. So CDC has identified a list of conditions that make an individual at increased risk of severe disease, severe COVID. This list is not exhaustive and only includes conditions with sufficient evidence to draw those conclusions. High-risk medical conditions may include there may be other individuals based on consultation with a healthcare provider about personal risk factors. So the conditions that have attained the necessary evidence to make it onto that list, and again, this is a constantly ongoing search of the literature that a team at CDC does. The conditions that have been shown to be associated with severe disease are listed in the table, and I think if there's any clarification questions, we can take those.
Very good. Are we open for questions or discussion? Dr. Atmar, your hand is up first.
For smoking, is that current or history?
That's correct. Smoking is current or a history of smoking.
Thank you.
Dr. Paling.
So first of all, thank you for pulling all this information together so we can review it. I think it does highlight the fact that you need enough people with a certain disease to be able to rise to this list. To me, the mechanism behind type 1 and type 2 diabetes is not very different. The complications associated with type 1 and type 2 diabetes are quite similar, and type 1 being much less common. And I do worry that type 1 is not showing up just because of the numbers.
Thank you for that.
Your thoughts on that.
Thank you for that comment, and I think that's addressed by the second point, which is that this list is not exhaustive, and you're absolutely right that enough literature needs to come to the fore for it to get on the list, and really it's in consultation with a healthcare provider that personal risk factors are best assessed.
Dr. Fry.
Thank you. I wanted to ask about chronic lung disease. I see COPD, but there are a lot of other chronic lung disease that are also incapacitating.
Yes, and again, those may come to the fore as time goes on and we learn more about this condition. But the conditions that are already here are certainly extremely prevalent in the population. An analysis with the behavioral risk factors, BRFSS, demonstrated that in the population 16 to 64, that at least 56% of the population has at least one of these conditions.
Dr. Lee, please.
Thank you so much for putting this together. I appreciate it. And just wanted to also highlight, I appreciate that healthcare providers can use their clinical judgment about the individual risk that any patient might have, which I think will be helpful, because I do think, as was pointed out, there are many types of lung conditions that don't necessarily meet the definition of COPD, but might be extremely relevant in terms of risk of severe disease due to COVID-19 infection. I'll also just highlight that this predominantly focuses on adult populations. So, going forward, as vaccines become available for children, I think it might be helpful to further detail risk for pediatric populations, because some of these conditions do translate over and others perhaps might be more adapted, and whether that would be done through epidemiologic studies versus sort of clinician judgment. But I think it'll be helpful for planning purposes for our healthcare delivery systems.
Thank you for that. There is a pediatric list that's on the CDC website as well. This is the adult list.
Thank you. Dr. Bell.
Thank you. I think it is quite useful to have this list up here for everyone to see and think through. I want to just draw people's attention to what Dr. Dooling just said, which is that the list as currently configured includes something more than half of the adult U.S. population. And so I think that in the context of limited supply, which is where we are and will be when we get to phase 1C, I think this is one of the challenges and something that the committee will need to deliberate on further, I think, because this list is not, ordered in terms of strength of association, as simply a reflection of conditions that have been shown to confer increased risk in epidemiologic studies. So while I certainly think it's useful and is something for us to work from, I think that in the context of prioritization, which is presumably what we're going to continue to need to be doing, unfortunately, for a little while, as I say, I think there's some further things that the committee will need to consider.
Thank you. Dr. Atmar.
Thank you, Dr. Romero. I have a question related to heart conditions and more specifically to hypertension, which was on some of the early lists of more severe disease. So I guess my question is, hypertension contained within heart condition, which is really a pretty generic category compared to, for example, COPD is a subset of lung condition.
We're just
But
checking.
my question is, hypertension part of heart condition?
Go ahead.
This is Dr. Oliver. So the CDC website says heart conditions such as heart failure, coronary artery disease, or cardiomyopathies. So it appears to be highlighting those. It does say pulmonary hypertension.
Okay, so not hypertension fell off some of the early lists,
well,
and is no longer.
Yeah, there's an R at increased risk and might be, and there is a note that says having other cardiovascular disease such as hypertension or stroke might increase your risk of severe disease from COVID-19.
Thank you for the clarification.
Thank you. Any other comments or clarifications? Okay, I'm not seeing any. Very good. Good. So are we ready to proceed to a vote?
Yes, we are pulling up the language. Great. Dr. Dooling's going to read the language, and then we're asking the ACIP members to turn on their video again so we can vote. And then Dr. Romero, do you want to say anything before the vote? And we're going to allow each of the ACIP members after the vote to make a comment if they wish. Are there any other things you wanted to say before the vote?
No, I think for those in the ACIP, I think these recommendations reflect the very careful deliberation that we've had and the careful examination of data, and they really serve to address the current lack of vaccine supply and addresses those individuals that have the highest risk for disease. And as has been said many, many times, it minimizes the disease itself and improves the equitable distribution across all sections of the society. So we'll go forward. Dr. Dooling, please.
Thank you, Dr. Romero. The proposed interim recommendation is as follows. As an update to ACIP recommendations for vaccination in phase 1, healthcare personnel and long-term care facility residents, if COVID-19 vaccine supply is limited, the following groups should be offered vaccination. Phase 1B, persons aged 75 years and older, and frontline essential workers. Phase 1C, persons aged 65 to 74 years, persons aged 16 to 64 years with high-risk medical conditions, and other essential workers.
Very good. So I will call your names, and hopefully I will not forget anybody today. We'll start with Dr. Atmar, and please indicate whether you are in favor of this interim recommendation. Dr. Atmar.
Atmar, yes.
Dr. Alt.
Alt, yes.
Ms. Bata.
Bata, yes.
Dr. Bell.
Bell, yes.
Dr. Bernstein.
Bernstein, no.
Dr. Fry.
Fry, yes.
Dr. Hunter.
Hunter, yes.
Dr. Lee.
Lee, yes.
Ms. McNally.
McNally, yes.
Dr. Paling. Dr. Paling, you may be on mute. Let me return to Dr. Paling, continue down the list. Dr. Sanchez.
Sanchez, yes.
Dr. Szilagyi.
Szilagyi, yes.
Dr. Talbot.
Talbot, yes.
Let me return to Dr. Paling.
Paling, yes.
Thank you, Dr. Paling. Jose Romero, yes. So Dr. Cohn, my tally is 13 votes in the affirmative and 1 against.
Yes, I concur, so the motion passes.
Thank you very much. Would anyone wish to make comment about why they voted the way they did? Dr. Alt, your hand is up.
I appreciate the amount of work that's gone into the discussions in the work group, and I have been relatively silent in all this forethought that went in. However, I thought that the public comment section did raise some points, and I want to make sure we don't have any gaps. Reflecting the comments that we got, is there a way to mention in our clinical guidance that there may be persons under 75 who are, not at home with caregivers, and to try to get that group of people vaccinated?
This is Dr. Oliver, happy to address in the clinical considerations.
Thank you. Dr. Paling, please.
Yeah, thank you. With the approval of 2 COVID vaccines and more studies currently ongoing, we have the hope of ending this pandemic. While we want to provide vaccine to all Americans who want it, we are asked to provide recommendations during time of limited vaccine availability to ensure safety and effectiveness, minimize transmission, morbidity, and mortality, minimize social disruption, and ensure equity in allocation distribution. I have voted for this prioritization schedule. Would like to note that the persons 75 years and older represent 8% of the population, 25% of hospitalizations, and have a very high death rate. Frontline essential workers have high exposure. They include a disproportionate share of race and ethnic persons who also have a disproportionate share of hospitalizations. I want to highlight the need for federal support to move efficiently and effectively so that all Americans who want to be vaccinated can do so. Federal support is needed to not just develop the vaccine, but also to support the infrastructural needs of state and local public health and healthcare organizations to educate and administer vaccine to our communities. Thank you.
Thank you. Ms. Bata.
Thank you, Dr. Romero. I just wanted to emphasize your comments prior to our vote and the importance of that, but also make sure that as we look at these priority groups, that we are looking at how we can reach those who don't access healthcare readily, may not have access to healthcare. And so as much as we can in our guidance, I think it is critical for us to urge both our state and local jurisdictions to plan out those groups that wouldn't readily walk into a facility to get vaccinated. Thank you.
Thank you. Ms. McNally.
I voted yes today after hearing the data and the goals-guided discussion. I want to make 3 points. First, I support the state's flexibility to adapt the guidance as needed, but recognize there may be challenges with this flexibility. I hope states will have as much support as necessary to succeed in getting people vaccinated. Second, I appreciate the work group and CDC's ongoing consideration of the priority of issue in persons age 65 to 74 that was raised by Dr. Bernstein and discussed by the ACIP today, as well as those issues raised by Dr. Lee and the additional clinical considerations around 1C. And finally, as a consumer representative, I place value on public input, and I very much appreciate the CDC and work group's attention to the feedback provided via focus groups, surveys, and the public comment on the Federal Register. Thank you.
Thank you. Dr. Szilagyi.
Yes, thank you, Dr. Romero. I want to say that I voted for this recommendation because, in my opinion, it follows the evidence about the risks from coronavirus and the ethical principles that we have developed on ACIP to maximize the benefits and minimize harms, to promote justice, and to mitigate health inequities. We are trying to thread the needle here. This was a difficult decision for me, really difficult, because I truly wish everyone could get the vaccine today, and I know high-risk individuals are not included in phase 1B. But over several months, as vaccine supply ramps up, every American will have access to these safe and effective vaccines. And we now, as others have mentioned, need to devote sufficient resources to implement the vaccines, resources to communicate the benefits and risks of the vaccines, and to provide outreach to at-risk communities who are disproportionately affected by the pandemic. And finally, I really want to thank the scientists, the CDC, ACIP, the liaisons, and the public who have helped bring coronavirus vaccines to our nation. Before too long, vaccination and public health will triumph over this pandemic. Thank you.
Thank you. Dr. Sanchez.
Thank you, Jose. I voted yes, but I really do want to reiterate my concern about, and hopefully the rapid introduction of the vaccine into phase 1C as obviously becomes available, because I really feel strongly that the elderly and those with high-risk medical conditions really should be upfront over some essential workers who may be younger. I'm not doubting that. I don't say that some of them may have severe disease, but I think we have to protect those elderly and high-risk medical condition individuals. So, but I am also I voted yes because I know that that there will be some prioritization schedule laid out to try to implement vaccination in that group. I also do want to echo someone's the public comments that there are elderly homebound individuals who who are not in long-term care facilities, and I think those individuals really, we need to reach out to those who are homebound and being cared by family members, because it really is an important group that needs to be vaccinated as well. Thank you.
Thank you. Dr. Bernstein.
Thank you. I am in full support of persons age 75 and older and frontline essential workers being in phase 1B. However, I voted no because I feel that the science regarding COVID-19 morbidity and mortality presented today by Dr. Dooling supports notable similarity between the 65 to 74-year-old group and the 75-year-old and older group. Therefore, inclusion of the 65 to 74-year-old group in phase 1B made more sense to me. I also believe overall implementation of this unprecedented, complex, and national vaccination program will be simplified by doing so. Thank you.
Thank you. Dr. Bell.
Thank you. I just wanted to say one or two additional things, share a few thoughts. First of all, I will say that I wish we didn't have to be here making allocation recommendations, and that instead we had enough vaccine to provide it to everybody in the country who wants it. But in that we can't, we are doing the best we can to make the best allocation recommendations. You know, people say that emergencies bring out the best in people, and it's been my experience that emergencies do bring out the best in people. And so, and this is a situation, I think, with this emergency where everyone has to do their part. We have to trust that everyone is doing their best and doing their part, and that we can all work together. And I see the ACIP's job and my job in a way as doing our best to create the conditions for success and to facilitate this sort of feeling of trust and of everyone doing their part. And I hope that this is an additional step in us doing that and trying to bring people together. One last thing I'll say, which others have said, but I feel is quite important, so I'll say it again myself, is that part of facilitating people doing their part is providing the conditions which makes that possible. And in that regard, the fact that the state and local health departments have not been funded for vaccination programs, especially in the context of the billions of dollars that funded the extremely successful program to develop vaccines, is really appalling. And I'm just one person, but I would just like to say again that I hope that the government will address this discrepancy without which I think it's going to be very difficult for us to be successful. Thank you.
Thank you. Dr. Talbot.
Yes, and I really want to thank Dr. Bell for highlighting how difficult this has been for all of us. For every group we add, it means we subtract a group, or for every group we subtract, it means that they don't get the vaccine. And it has been incredibly humbling and heartbreaking. And I look forward to everyone having this vaccine and can't wait, and hope to have a big party. I'd also like to really thank the CDC members that have helped us through this process. It has not been easy, and they have worked tireless hours, and I cannot say enough to thank them. And lastly, to be a broken record, because I think it's incredibly important that our White House senators and congressmen hear this, fund the vaccine infrastructure to get this vaccine out. This needs to be done rapidly, and it needs to take precedence. Thank you.
Thank you. Dr. Lee.
Thank you. I wanted to just make a couple of points. One is that our goal at ACIP is to ensure that we're providing access to safe and effective vaccines for the entire U.S. population, regardless of age, gender, race, ethnicity, or even personal or political beliefs about vaccines. I really see vaccines as a tool for creating hope, unity, and a stronger community together. However, we have seen vaccines become used as a tool for misinformation, fears about allocation, and division within our communities. In order to transparently explain my thinking about the vote, I wanted to emphasize that ACIP is currently prioritizing vaccines to those at greatest risk for infection due to their occupation, such as frontline healthcare providers and essential workers, and those at greatest risk for hospitalizations and death, such as long-term care facility residents, older adults, and those with high-risk medical conditions. These priorities reflect the racial, ethnic, and socioeconomic diversity of our U.S. population. And it also reflects that not all of us in the U.S. carry an equal share of the burden of COVID-19 infection and disease. So my hope is that these short-term recommendations will support efficiency and equity in every phase of vaccination until we can get to the time when all individuals have access to safe and effective vaccines in the U.S. and worldwide. My hope is that despite the divisive voices we sometimes hear, that all Americans can look to the ACIP, our federal, state, and local public health leaders, and our provider communities to serve as trusted voices and partners in the effort to end the pandemic. Thank you.
Thank you. Dr. Atmar.
Thank you, Dr. Romero. I want to add my voice to how difficult a decision this was. Probably the most difficult decision I've had on my term here at ACIP. And ultimately, I voted yes because I thought that the data that Dr. Dooling and Dr. Oliver presented to us and the consideration from the work group supported the allocation of or the prioritization of individuals into groups 1B and 1C. I feel comforted by the ethical framework that has been provided and the flexibility that local jurisdictions will have to make this prioritization recommendations fit into their local needs. And we've already heard both through public comment and through discussion that there can be exceptions that are not specifically considered in the groups that have been identified here. And then finally, I want to add my voice to the call for funding of the public health infrastructure across the country, because my concern is that without this funding, the equitable distribution of vaccine to the groups that have been identified as at greatest risk could be jeopardized. Thank you.
Thank you. Dr. Fry.
Thank you. I also would like to say that I was very much in favor of this recommendation. I'm in favor of the language of the recommendation and the intent of the recommendation set by the working group to provide vaccine as quickly as possible to those at greatest risk of contracting disease and also those who will suffer the most severe outcomes. These were difficult decisions, and there are no perfect recommendations. And people will continue to become ill with this disease and die from this disease until there's adequate vaccine. So I will plead also for our leaders in the government to move quickly on this and support this effort. The bottom line is that the decision-making will fall at the level of the local government and those people tasked with making this rollout happen. And my hope is that we are able to provide them with significant and slightly more detailed guidance for their use that they can use as the fluid parameters and conditions of deciding who needs to be vaccinated first will be available to them for their use. Thank you.
Thank you. Dr. Hunter.
Yeah, it's Paul Hunter. I just wanted to say I strongly support the recommendation and that it's been a privilege and an honor to work with the CDC staff and my fellow ACIP members over the past 4 years. Thanks.
Thank you. Is there any other voting member that wishes to comment? Very good. So I won't make long comments. They've all been mentioned before. I just want to say that the group has deliberated very carefully on this. This is without doubt the hardest vote that I have taken in my 6.5 years on the committee. I am confident that we have arrived at this by examining the data thoroughly, and that what we are providing, as has been stated before, the ultimate decision will be at a local level. But what we are providing governors, health officials with is a framework which is supported by evidence and will address this limited supply of vaccine that we have at this time and will maximize benefit and minimize harm. So with that, I'll end our comment and we'll turn it over to Dr. Cohn, who has some words.
Great. Thank you, Dr. Romero, and thank you, ACIP members. This will conclude the very, very many meetings we've had over the last several months. We do anticipate that we will be having more. We have our next scheduled meeting at the end of February, but I just want everyone to be aware that we will likely have one meeting before February. You heard some of the topics that have been raised today that will need further discussion, as well as hopefully some additional information about additional vaccine products. So be on the lookout for those dates. I want to end the meeting, or I want to end the meeting by sharing some new numbers that were just published on the CDC website at 1 p.m. today, and this is at cdc.gov/coronavirus. It's a little hard to find /2019-nCoV and /vaccines. Within the last week, we started shipping Pfizer vaccine last weekend. And over the last week, 2,838,225 doses have been distributed, and 556,208 doses have been administered. So that just reflects what is just an amazing amount of work that is happening at all of these administration sites, and the amount of excitement and hope, as many of you have seen from pictures that have been all over social media, for healthcare workers and soon long-term care facility residents as well. We will now have 2 products. And so while we talked all day today about limited supply, I just want to remind everyone that this is also really an incredible feat that we have vaccine so quickly, and that we will have more doses, and we are hopeful that they will continue to increase production, as well as potentially have new products early next year. So these numbers will be updated on the ACIP regularly. I also just want to thank Dr. Romero for managing these meetings so seamlessly over the last couple of months, and then finally Dr. Stooling, Dr. Oliver, and their entire team for the really, I can't even quantify the amount of work and thought and effort that has gone into the last several meetings. I also just want to thank Stephanie Thomas, Chris Caraway, and Jessica McNeil, who always make sure our meetings run smoothly, even as we have transitioned to this virtual platform. So I guess before we go, I do hope that I get to see all of you soon, because we'll all be vaccinated and be able to return in person to ACIP meetings.
Thank you, Dr. Cohn. I want to thank all of you for all the work that you've done. Tomorrow is the winter solstice. I ask you to take a few moments to reflect on this and take care of yourselves. I will see you all in the near future. Please have happy holidays, a prosperous new year. And with that, I gavel this meeting to a close.